Thanks for having me here. It's a privilege to be speaking on this topic, which is quite relevant. And as busy cardiologists, we all come across these subsets of patients in our daily practice, and there are many issues related to this topic. At times, we do a PCI and find out a patient bleeding from upper GI, have a patient getting hematemesis, and I tell you that is a worse scenario because that suddenly erupts so many issues. What to do? Obviously, the gastroenterologist would say that this is the time to stop the antiplatelets. And once we have either stented left mains or proximal LEDs, it's actually horrifying to think of this scenario where we have to stop the antiplatelets. So that is the topic which I am speaking upon, defining high bleeding risk and optimizing outcomes in patients of high bleeding risk. What is the data? So I'll start with the patient history. This is a real life scenario. I just did a patient a few days back. So from there only, I could see what's happening. So this patient was 65-year-old male who presented with unstable angina with STT changes in the ECG. Historically, patient is a old patient of liver cirrhosis, and then once we have done the investigations, the platelets were found to be 80,000 and a deranged INR. So this is the status of the patient, and see the coronaries. So now obviously he was having unstable angina from a tight lesion in the proximal LAD. And not only that, there is some lesion in the mid LAD, and RCA also was diffusely diseased. So this is the scenario which we come across, and then lots of thinking have to be done in such patients. So let's see what is happening in this patient. Clearly, this is a true high bleeding risk patient, no doubt about that. And then the next questions which emanate out of this, which come across our minds as an interventional cardiologist, are still many unanswered questions. So I'll come to that. But as far as this patient was concerned, as INR was more so deranged, so we got the INR corrected by transfusions and then planned the patient for PCI. Surgery was out as the patient is a liver cirrhosis patient with deranged bleeding parameters. The further important decisions which are very relevant and very important in such patients are, now once we are through and planning a PCI, what should be the choice of drug-eluting stent in such patients who are a high bleeding risk? I think that is very, very relevant and pertinent point, which we should know, and we should know what the data suggests. Use of imaging during the PCI, should it be absolutely essential? Because at some point we are anticipating that we may have to withdraw the antiplatelets, and obviously the scenario would be, making the patient more vulnerable for future events, be it stent thrombosis or target lesion or vessel revascularizations. The choice and duration of dual antiplatelet therapy, again, highly pertinent in this context. Not that it is pertinent otherwise also, but in this context, it becomes very, very important. Now let's see, let's go towards the data and find out answers to these three questions. Now we all know that these are the major bleeding risk situations: oral anticoagulation, patient if on oral anticoagulation, low platelet count, bleeding diathesis, liver disease, active cancers, and then prior history of ICH, less than 6 months or recurrent, any bleeding or requirement of transfusion. So all this we know. So out of this, if the patient has one major or two minor HBR criteria, patient is considered highly vulnerable for high bleeding risk. And these are the guidelines as far as they are applicable. As for now, these are the active guidelines that if we do a PCI in acute coronary syndrome patients, in HBR patients, the guidelines say we should continue the DAPT for at least 6 months. And if in stable patients, it's variable. The US guidelines say 3 months, and the European guidelines say that 1 month is essentially it is required, and then one can think of discontinuing after 1 month. So these guidelines are based on various studies, which include the Endeavor drug-eluting stent, Leaders trial, and the other optimize and reset studies also. Although uh, the level of evidence towards a decreased usage of dual antiplatelets, even in acute coronary syndrome, exists with trials. But as far as the guidelines exist, these are the guidelines. Now let's see the data. Onyx 1 trial is one good trial. Now we have final 2-year results which were presented at ACC, and it included almost 1,000 patients in each arm, where Onyx was compared with biofreedom stent and in all HBR patients. So this is how the patient inclusion was done. These are the all the inclusion criterias. Won't go into the detail. Just one enumeration point. Now this trial included almost 52% of patients who had acute coronary syndrome. This is what I was trying to highlight here. So acute coronary syndrome in Resolute Onyx arm was 52% and in Biofreedom arm was 50%. Besides all diabetes, hyperlipidemia, and atrial fibrillation patients. Results. So it was a non-inferiority trial. It clearly established that Onyx is clearly non-inferior to Biofreedom, as both the graphs were matching even at the end of 2 years. Once we talk of composite end points of cardiac death, myocardial infarction, and stent thrombosis at 2 years. So no difference in BARC 3 to 5 bleeding rates also in both the arms. So Resolute Onyx drug-eluting stent was safe, effective in high bleeding risk patients with diabetes or no diabetes in both the arms. Resolute Onyx drug-eluting stent was again safe and effective in high bleeding risk patients with atrial fibrillation on 1 month DAPT. So it concluded that Onyx is a safe and effective real world uh, choice of stent in high bleeding risk patients on 1 month DAPT, and after 1 month, the DAPT can be switched over to single antiplatelet. The Resolute Onyx showed a continued safety and efficacy in complex high bleeding risk patients with a good follow-up even at 2 years. So these results were maintained even at 2 years. So now after this, it is CE and FDA approved stent for a smaller period usage of DAPT in HBR patients. So wherever possible, if we have a situation like this where we think we need to withdraw the DAPT after 1 month and the patient is HBR patient, I think this is one stent which is approved, and we have a good data to back this stent for these subsets. Leaders free trial, Biofreedom was compared to bare metal stent. The results were clearly in favor of uh, the drug coated stent versus even a bio BMS, and primary safety endpoint was also still in favor of drug eluting stent, biofreedom stent as compared to BMS. So these were the results of Leaders trial. And then we also have a data for Zines stent, Zines short DAPT program, Zines 90 and Zines 28. Uh, there was some difference as we talk of inclusion criteria of Onyx 1 and Zines programs like this. I'll talk about that. Now Zines 90, once we talk that after 90 days, the DAPT was switched over to single antiplatelet. The results were almost the same in both the arms, where it was not switched and DAPT was continued, and where the DAPT was switched after 90 days to single antiplatelet. Similarly, even after 28 days of switch from DAPT to single antiplatelet, both the groups were behaving in a good way. So this is an important slide which tells us a short DAPT trials comparison. Just a minute on this slide because this is very, very important. The Onyx 1 global trial, where it was tested up against the biofreedom, and it was the lesions were more complex in this trial. Almost 80% were B2 or type C lesions, and average length of stent was 38. So and almost 50% were moderate to severely calcified lesions. So it actually included more complex lesion subsets. And results, we have all seen that even after 1 month of switch from DAPT to single antiplatelet, the results were very good in this trial. Let's see the Science 28 study. Now, it again was a good study, but it excluded more complex subsets, left main CTOs and overlapping stents, they were excluded. And so, similarly, this resulted in less percentage of more complex lesions in this study. And similarly, we also have a study with synergy. Again, the if we talk of the percentage of more complex lesions, it was maximum in Onyx 1 as compared to these other two stent studies. So finally, it tells us that how can we conclude? We know that high bleeding risk patients, they are more vulnerable for incidence of bleeding, and since there is a more incidence of bleeding, there is inhibition of carrying on with an intense dual antiplatelet regime, and that also leads to more vulnerability for thrombotic events. So both these things are associated with high mortality over 1 year. So based on this, I think it is quite imperative that we think very meticulously for these subsets in planning our procedures and picking and choosing the stent and uh, the DAPT regime duration. So all these things become very meticulous, and we should do it with a proper planning. So let's see where we started. We asked three questions in the beginning. Let's see the answers to those questions. Our first question was the choice of drug-eluting stent in high bleeding risk patients. So as far as the data stands, I think we can have Resolute Onyx, Zymes, Synergy, or Biofreedom, but data-wise, it's more robust in favor of Resolute Onyx. The use of imaging, I think I would again very emphatically put stress on the fact that imaging should be done in these subsets, because if we are having under expansions and malapposition, that may lead to more vulnerability for such patient subsets for thrombotic events, because we are going to withdraw the antiplatelets or maybe switching the antiplatelets from dual to single antiplatelet agent. So imaging is should be done more frequently in such subsets, or I would say essentially should be done in all patients of high bleeding risk. And thirdly, the choice and duration of DAPT as far as the data stands, depending on the risk of bleeding in such patients, aspirin and clopidogrel. First of all, we are not uh, involving, or I'm not specifically mentioning ticagrelor here, because in all such patients, we are using aspirin and clopidogrel, and at least for a month, and then withdraw clopidogrel and aspirin to continue in all these patients. This is what we practice and what the guidelines also say. Although guidelines say for ACS patient 6 months, but I think based on the high bleeding risk, there is a data that we can withdraw the second antiplatelet after 3 months or even after a month. So individually, we can decide on patient to patient basis. Thank you.
Thank you, Dr. Rajneesh, for the nice presentation.
Dr. Kapoor, great summary. Did you consider also to think or to replace aspirin with clopidogrel? There is some new data according this point.
Yeah, I think so. So it all depends, depending on the risk of bleeding. But yes, we can have, the data says we should switch from double antiplatelet to single antiplatelet. It can be clopidogrel also once we can stop the aspirin after a month and then continue with clopidogrel. More so if there is a history of any gastric bleeds. If there is a history of any peptic ulcer bleed, then aspirin is bigger culprit as compared to clopidogrel in gastric bleeds. So I think in those cases, surely, but otherwise also we can think of the biggest dilemma is in patients of atrial fibrillation, where we give triple regime for 1 month and then withdraw aspirin and continue with clopidogrel and oral anticoagulant further on as the patient is having atrial fibrillation. So point well taken, and I think need to be discussed that what is the choice of antiplatelet after a month.
Yeah. Any other comments or remarks from faculty? If not, we would go forward. And thank you, Dr. Kapoor.